Good afternoon. Welcome to the symposium, the Heart Team in Structural Intervention, a Permanent Revolution. I can tell you we're going to be as controversial, as provocatory as possible. Provocation is going to be, my presentation is going to be very provocative. But I would like to ask Saibal to introduce the objective of the session.
So I'm not going to be provocative like the previous session. Oh, whatever.
Yeah.
So these are just going to be the session objectives. So these are the structural heart disease intervention in the new revolution, some of which we're going to focus today on: valvular heart disease, treatment and prevention of cardioembolic stroke, closure of PFO atrial appendage, alcohol septal ablation, closure of cardiac defects, creation of intraatrial shunts, and it continues. So it's a true revolution. And when you look at the structural heart team, and what you notice over here, initially it started with just 3 people: surgeons, cardiologists, and imaging. Now look at this list that we have: referring cardiologists, cardiac surgery, imaging specialists, interventional cardiologists, heart failure specialists, cardiac anesthesia, nursing staff in ICU in the cath lab, fellows, allied health professionals like NPs and PAs, research staff, and perhaps most important, which we forget, is the patients themselves, because that's who we're treating. And the reason why I'm showing you this large list, because everybody in this large list plays an important role in the treatment of these patients. So the session objective is to learn the best practices on decision-making within a structural heart team, to learn how emerging clinical evidence and innovation will shape the team and who will actually lead this team, and to learn why a heart team is so crucial for setting up a center of excellence. With that, actually, I would like to introduce the first speaker.
The first speaker is going to be Ganesh Manoharan, who is going to talk about the TAVI, impact of upcoming evidence. We start the session starting from state of the art of the heart team, which is aortic valve intervention.
For 1 hour.
Thank you very much for the opportunity. So the heart team in structural intervention, a permanent revolution, the impact of increasing evidence. I wholeheartedly believe in the statement, but I am going to show you some evidence on why I think going forward this concept may not entirely hold true for every single one of our patients that we deal with today. And so I will be a little bit controversial, and you're more than welcome to challenge me. So what do the guidelines say? It says decision-making of intervention should be made by a heart team with particular expertise in valvular heart disease, comprising of all the people that Saibal has shown. The guidelines also say that the requirement of a heart valve center has to have technical expertise, imaging expertise, and the ability to communicate and teamwork with every referral pathways. It goes on to say that the aortic valve intervention should only be performed in centers where there's both good collaboration between the cardiologist and cardiac surgeon, i.e. the heart team, which is class 1 level evidence C. It also says that for surgical aortic valve replacement is recommended for low-risk patients. TAVI is recommended as in class 1B. TAVI is recommended for patients who are not suitable for surgery. And in patients who are intermediate risk, where they may have another risk factors like porcelain aorta, then they should all be discussed at the heart team. And then they also then very nicely laid out parameters that favors TAVI versus parameters that favors surgical AVR in some of these very, very complex patients. And all of this should be discussed by the heart team. And hence, they came up with this nomogram, which clearly shows that if you are high risk, low risk, should go for surgery. But if there are any high-risk features, then they should be very carefully assessed, individually assessed by the heart team, and then to be considered for surgical AVR and TAVI. And I completely agree with this historically. What's the evidence to support all of this? For inoperable patients, the partner trial has shown very clearly in the high risk, in the inoperable patients, medical therapy is inferior to TAVI. In the surgically high-risk patients, TAVI was equivalent to surgical AVR. That has been followed up by the CoVAV IDE trial, which again compared surgery versus TAVI in high-risk patients. And this is the first trial that shows that TAVI was superior to surgical AVR up to 2-year follow-up, and now even up to 3-year follow-up. In the intermediate risk group, we've seen that the Partner 2A trial comparing transfemoral versus transapical against surgery in intermediate groups patients, that TAVI was as good as surgery when all patients were taken into account, but TAVI was superior to surgery when transfemoral approach was found. So these are intermediate risk patients. And similarly, in the TAVI trial, again looking at intermediate risk patients using the COVARP device, and something similar was seen. TAVI was similar to surgical AVR in the intermediate risk group. But the objective of the heart team, however, is to make sure that we give the right advice for the patient to get the right treatment. It should allow borderline cases to be discussed in more detail and consensus be obtained. But I would suggest to you, ladies and gentlemen, that today we should not be discussing every single case, and I don't think every single case should be discussed or must be discussed. I believe it's going forward, it's going to be impractical, undeliverable, and probably unnecessary. And I'll tell you why. The impact of time, it is going to be significant. It takes and Saibal has shown you the list of people, 2 cardiologists, 2 surgeons, 1 anesthetist, 1 imaging specialist. Let's say they spend 4 hours a week discussing these cases. That comes to, when you do the maths, almost 1,152 working hours per year per individual per center. All talking about whether somebody who's 85, 88, or 90-year-old should get surgery or TAVI. We have evidence for it to say these people should just get TAVI. And this is even before we start talking about moderate risk patients, low risk patients, mitral valve, and everything else. We know that the population we work in are increasingly getting older. And Marty has shown, this is now going back 2 years ago. In 2016, this is the growth predicted for TAVI usage with the current accepted use of TAVI. Not even the moderate risk patients, not even the low risk patients. So there's going to be an exponential increase on the requirement TAVI in your center, in your region, in your country. So the impact of TAVI program today, if you do 50 cases today, you're going to be doing 75 to 100 next year, the year after. So that you can see even in your own centers in the last 5 years, 10 years, you have seen a gradual progressive increment on cases and volume. If you discuss every single one of your cases today, in a conservative estimate, assuming you take about 60 minutes to do a TAVI under local anesthesia, you're potentially going to miss doing about 1,100 odd cases per year because of you sitting. Correctly, I would agree, but impracticably talking about every single patient in your case. That is a significant loss in number of cases, never mind the revenue. Imagine the impact on time and resource of the team when you start doing with mitral valve replacement, mitral clip. It's going to be hypothetically awesome to be able to discuss every single case, but it's going to be impractical to discuss every single case. Imagine tomorrow if you're going to discuss every single stent that you put in the patient on a heart team before you put the stent. That is what we're going to be talking about, because that's how TAVI will, I think, progress. I think TAVI has come in a long way in a very short time. In 10 years, we have now abundance of data. There's more data for TAVI in a randomized manner than putting a left main stent in a randomized manner. Yet, we don't discuss every stent we put in left main. We are supposed to discuss every single TAVI we put in a patient today. So I think that the guidelines should have this additional bit that I've added on. I think people who are high risk, who currently clearly meet the guideline requirements, who are elderly, who have features that TAVI has been shown clinically to be superior, should go straight to TAVI in experienced centers. So I think, in my view, a very humble view, I believe that I think the heart team concept should evolve with time, with everything we do with time, should be designed to provide the best care for patients. I think it should involve patients' opinion and views, especially in borderline cases. I think it should not be used as a regular tick box, which sometimes happens in some centers. There should be frank discussions in the moderate patients or difficult anatomies or difficult challenging cases. But I hope I made some case that I think going forward, I do not think all cases need to be discussed so that you can go ahead and offer what is right for the patient. Thank you.
So Ganesh, I think you're gonna leave soon, right? The room.
No. So I'm here for the good. Until 6
stay
o'clock.
Until the end.
I'm here
right,
until 6
because
o'clock.
so this is a autocratic approach that you're proposing, where you don't want to have discussion, right?
No. I'm
No,
open.
that's just.
Listen, I'm open.
You know, this is gonna be the most funny session at PCR this year. I tell you, the guys here will remember forever. because we're gonna kick ass each other, and we don't know what to do, but it's fantastic. So you are the autocratic, yeah, state it. Democratic, no, because you don't want to discuss, right?
No, I think it's two reasons. So today we have guidelines to do what is right in the cath lab for pacemakers, for stenting, for left main stenting. And why are we excluding TAVI from this normal pathway?
I agree. I'm not discussing
Yeah.
the background. So autocratic, that's good. Just put your jersey.
It's
You
an
have a
opinion,
jersey
but,
which is the red jersey. It's like Republican.
Yeah.
No,
It's all
Francesco, Francesco, you invited controversy, and I want to ask Ganesh. I heard at the CRT meeting, the panel of surgeons, and they said the heart team concept is so good. No surgeon should be able to do a surgical valve without the approval from the heart team, the cardiologist. So that should be the next step. Now surgeons, whenever they want, they put a valve. But the evolution of the heart team should be going both ways. What do you think of that?
Again, I think, if tomorrow I have 48 hours in a day, and I live in Mars where the it revolves much slower, then I think we should discuss every single case. There's no question. I think we as a group, I think we've learned a lot. I'm not saying get rid of the heart team. I think the heart team should now discuss what is more relevant, which is the moderate risk patients, the low risk patients, the valve-in-valve cases, the bicuspid cases. I think if you start discussing those cases, that will take more than 2 days per week because of the volume of cases alone. I just think that if you have an 85-year-old, 88-year-old, nice juicy left femoral, you can close one eye, puncture from across the room, you can get the fellow to advance the valve, because the technology has now evolved significantly. It's resheathable, repositionable. You can probably remotely deploy some of these valves if you really, really want to with technology. So I think in those kind of environments, I really do think we should not. I don't think it's practically possible for you to discuss every single case going forward.
Thank you, Ganesh.
Thank you.
So we're going to ask, we're going to actually have more discussion about it.
It's not finished
It's
yet.
not finished. We're going to ask the panel. We're going to ask Lars Sondergaard to be talking about rethinking the valve selection in TAVI.
You go, Lars. No. Hope you have funny
And you
slides.
can state your position, whether you are Democrat or autocrat. To start with or at the end, you decide. If you
I can
state
give
your
you
position,
one comment,
Okay.
and I agree with Ganesh. This is the field where we have most evidence before it moves forward. And we got evidence because there's both been cardiologist and surgeon on board. If it's been driven alone by the cardiologist, it's been moved forward without evidence. So just keep that in mind. So I'm being asked to talk about rethinking valve selection in TAVI. You can guess which valve I'm going to talk about. The portico valve, and I'm just going to show you here some features about it and end up to show some of the new data we got. Francesco was presenting yesterday, and also about how to consider moving forward in even lower risk patient and younger patients. So the portico valve is a self-expanding stent. It was the first valve on the market which was repositional. It got leaflet made of bovine pericardium, which is stronger, hopefully more durable, and it's a sealing skirt of a porcine pericardium, which is thinner. It comes in 4 sizes, so it covers annulus range between 19 and 27 millimeter, and also you don't need rapid pacing during the deployment because the leaflets are in an interannular position, so you don't see any hemodynamic compromise. It's a valve which is very easy to rinse. It takes a few minutes to rinse it and to load it into the system, so it's a very simple valve to prepare. And also, we have seen for the trials that have been out there, this was before TAVI was published. This is on the 4 first randomized trials between transcatheter and surgical aortic valve replacement. And it's almost 4,000 patients followed for 2 years looking at all-cause mortality. And you can see that if the patient go for TAVI, you have a 20% reduction in all-cause mortality compared to going for surgical aortic valve replacement. And that's all driven by transfemoral approach. If the patient have an alternative access, you don't have any benefit compared to surgery. So everyone, of course, wants to go transfemoral. The problem is if you push it too much, you may have vascular complication, even fatal vascular complication, as in this case. So what you can do is that you can use some of the newer generation sheets where you have a sheet which is introduced as a small core, and with it in place, you can expand it up. Here with the portico-solar sheet, you expand it up to working diameter, you introduce your valve, you do your procedure, and when you're done, you recollapse your sheet and you take it out again. So that's going to open up for more patients who can be treated as a transfemoral approach. And again, remember, longitudinal stress through a vessel is much more dangerous than a radial stress. Radial stress is like a PTA. So if you use the solar power portico in combination with a portico solar sheet, you can see that portico is actually the valve you can get in on the smallest diameter. It's around 5 millimeter, Sapien about 6 millimeter, the Evolut Pro about 7 to 8 millimeter, and Lotus about 8 millimeter. Also, the frame is very, very flexible. So it'll take even very tortuous anatomy in the groin. It could be in the aortic arch. This is a patient where we tried to treat with a system which was not very flexible. And this procedure was done in local anesthesia, and during valve introducing, the patient was complaining about sharp pain in the back. We pulled the pigtail back, and we could see there was a perforation of the aortic arch. So since the same team was doing TIVA procedure, we had the CT scan, we could quite quickly measure the size of the aortic arch and put a TIVA graft in. But the patient was still left with his aortic stenosis. So what to do? So here we used the portico valve. You can see this is a TIVA graft which has been in for a few minutes, and now a valve is going across without any problem in this anatomy. And this flexible system is also very useful if you have horizontal anatomy. You can push on the wire, push on the system, and get it aligned, coaxial with the valve, so you have a very good implantation even in challenging anatomies. Most of the patients we're treating have severe calcification, and that's the main substrate for paravalvular leak afterwards. And there's several ways to try to minimize the degree of paravalvular leak afterwards. In the portico, the cells are larger, which means that some chunk of calcium can actually sit inside these cells and thereby minimize the risk of paravalvular leak. So this is one way to minimize paravalvular leak. And this is a patient, I think most will appreciate this will be a patient have a high risk after the procedure for paravalvular leak. And if you do the patient with a balloon expandable, you also have a risk of annulus rupture. There's massive calcification here. And you can see after portico implantation, you have a very, very favorable outcome. There's only a trivial to mild PVL in this anatomy. So this design also worked to minimize the paravalvular leak. The frame is also designed in a cylindric fashion. It's not a tapered fashion, some of the other self-expanding technology. So this means that it's not going to impede as much on the conduction system in the left ventricular outflow tract, and thereby minimize the risk of conduction subnormality. And as I said before, this valve was the first one on the market which was repositional. So this means that you can aim at a high position. The higher you implant, the lower is the risk that you're going to have a conduction subnormality with the need for a permanent pacemaker. And before we have reseatable system, most physicians was implanting a little bit low to make sure they didn't have a pop out. But now where you have reseatable system, you can be ambitious, you can go high, and if you're too high, you can recapture and redeploy, and thereby having less patient with conduction subnormality and ending up with a permanent pacemaker after that TAVI procedure.
Here, so we are so.
It's also, as I said, the leaflets are positioned in an interannular position. So this means that the leaflets are going to work as soon as you implant it. So you won't see that drop in blood pressure as you see within a supraannular position of the valve. So you can go very slow as you deploy it. You don't need to rush through the middle part. You don't need to pace. So you can take your time, let the frame work to expand fully to gain the full radial force during the procedure. And of course, this is a major benefit if you have patient with depressed LV function, a patient who's hemodynamic unstable, that you can actually do a safe implantation of the valve without any problem. The Portico 1 study was a real-world study run in Europe, in Canada and Australia, including 61 sites. So it's a real-world setting, and quite a few of these sites did their very first Portico implantation as part of the Portico 1 study. 941 patients was included here, and you can see it's typical TAVI patient, age 82 years at mean, STS score 5.8, intermediate risk, you would say. And you can also see the female is about 2/3, because when the study started, only the 2 smallest size valve was included, and was available. And here you can see the outcome of it. So it's a very safe procedure doing it. All-cause mortality at 30 days, 2.7%, disabling stroke, 1.6%. And if you look at the hemodynamic, you have very good outcome. Valve area 1.8 square centimeter at 30 days. And again, remember, 2/3 of the patients was female, so it's small patients. It will be even better if you have a normal distribution between the 4 valve sizes and mean gradient of 8 millimeter mercury. Paravalvular leak, and this echo was read by a core lab. It's not individual reading from the sites. More than mild, 3.9%. So this is, as you see it, in most of the best valves on the market. And not only this, if you look at the patients, the sites who have done less than 15 implants of Portico and the sites who've done more than 15, you see there was a change in PVL, moderate PVL in the experienced sites, 2.6%. So I think this is really as good as it gets nowadays with the TAVI procedure, and very close to what you can gain from surgical valves. I'm going to end my talk talking about coronary access. And it's something which is a little bit forgotten. What's going to happen when you implant a valve and you want to readdress the coronary arteries later on? And you can see if you have a frame which is low, internal position of the leaflets, it's very easy to access the coronary arteries afterwards. If you have a high frame, you can do it. It's going to be easier if you have intraannular leaflets than if you have supraannular leaflet, but it's still possible. But remember, TAVI is going to move from high-risk patients with limited life experience to low-risk patients, younger patients who have a much longer life experience. Maybe it's going to be a 60-year-old patient who's going to face 25 years of life expectancy. And these valves are going to fail at some stage. So when they fail, what people will do, they're going to do a TAVI in TAVI. If you have a low frame or you have a high frame, the interannular position of leaflet, you will still access the coronary arteries. But if you have a high frame with supraannular position of the leaflets, those leaflets are going to be pushed towards the frame and sandwiched between the 2 stent frames, and those coronaries cannot be accessed. You're going to have a tunnel of tissue extending from the left ventricular outflow tract through the ST junction into the ascending aorta. So that's worth to keep in mind when we're going to treat patients with longer life expectancy who need to have access to the coronary arteries in the future. So just to summarize, the Portico valve is easy and fast to load. If you use it in combination with the Portico solo sheet, it's the smallest introducer size, allowing to treat more patients as a transfemoral approach. Very flexible system, challenging anatomy, including horizontal aorta. Low paravalvular leak, you saw for the Portico 1, experienced sites, more than mild, 2.6%. Low pacemaker rate. It got interannular position of the leaflets, which is good for hemodynamic and particularly for accessing the coronary arteries later on. Thank you.
Thank you, Lars. I'm not sure that was the topic, but anyway, that was a great topic about Portico valve, and I realized it's an Abbott symposium. So,
it was the topic.
Any points of discussion or questions from the audience?
Yeah, just stand up.
So, yes.
Strömberg from Krakow. You said that the pacemaker rate was low, but it was close to 20%. Is it low?
I mean, if for self-expanding technology, the most you have to compare it with is Evolud-R, of course. And you're seeing that same range, a little bit high, is 21% at 30 days after using those valves. Again, these are very first experience from the sites. We also have data from more experienced sites where you have pacemaker rate down to almost 1 digit here. But I fully agree, if you're moving down to lower risk, a younger patient, this is for something we for certainly have to take into consideration, what a pacemaker rate. Pacemaker may be a benign accessory if you're an old patient, but if you're a younger patient, it could impact the outcome of the patient.
So, Lars, what makes you choose a self-expanding valve compared to balloon expandable valve? What is the driver, the main driver for you?
First of all, I mean, if you want to treat as many patients as possible through a transfemoral approach, I think self-expanding technology by itself have a smaller diameter. But also you can get even balloon expandable through expandable sheet from the groin. But I think you can treat more patients if you have a self-expanding technology. If you have a calcified aortic annulus, it's a more safe way to implant a self-expanding technology than a balloon expandable technology. You have a less risk of aortic annulus rupture.
And do you think that this technology prevents discussion with surgeons?
I don't think this technology by itself does it. And I think, again, back to the discussion, I like your talk, Ganesh. And I completely agree we shouldn't discuss every patient, but there's still a gray zone. And I think it's important that we discuss those patients with the surgeons and also that we continue to generate evidence in this field before moving not only to lower risk patients, but particularly going to move to younger patients.
So in reality, I want to ask a quick question of the panel. You can answer very quickly. Do you do every week a valve team meeting in your hospital? Saibal, do you do it every day, every week, a valve meeting?
No.
Jean-Francois?
Every week we have 5 meetings about valve disease, coronary disease, endocardial infection, and so it's almost impossible to attend all the MDT. So we have to select the one you prefer to go.
Okay.
2 per week. One is fixed on Tuesdays, and the other one is flexible on Thursdays or another day that is suitable to have a higher flexibility. We limit those meetings to 1 to 2 hours per day, so 2 times a week.
Lars, do you
Yeah,
do?
we do it. That's a valve meeting every single day. And we use the same matrix that you saw from ESC. So if the patient is an elderly patient, is a low ejection fraction and so on, he'll go straight for TAVI. But every patient is discussed with the surgeon. It may not take a long time as soon as you have confirmed that he has got aortic stenosis, and we follow this matrix. And then you have the odd cases who takes a more in-depth discussion.
So we have a weekly meeting, and we discuss all the cases for the upcoming week, also the cases that were seen in follow-up the previous week, and then quarterly review all the data and the quality metrics.
Yeah, but the reality is today we have a lot of patients coming today for therapy tomorrow. I mean, it happens in many hospitals. Sure. You don't have even time to discuss the patients. Sure. So the reality is that these patient discussions sometimes is my worst day of the week when I have to go to the valve meeting. I hate the valve meeting. I don't like discussions. I mean, who likes the valve meeting? Who likes the valve meeting? Who loves it? You love it. Ah,
me and Becky.
Somebody. How many surgeons are in the room? Who is the surgeon here? Why we talk about these guys? There are no surgeons in the room. Imagine this is one key element of the discussion today is that how many surgeons are attending this meeting, and I can do the same thing at a surgical meeting. How many cardiologists? Nobody. So this is the problem. I think this is the main problem we have at the moment. Why the heart team does not work. Because we don't communicate the right way, right? So I think it's one of the issues. I think what we have seen a platform of, this is let's say, 2nd generation / 3rd generation technology for TAVI. The early days was different. You needed a surgeon because most of these patients would die. It was an early stage, mortality was really 20-30%, and where there were conversions, etc. Now you don't need that. So we see that, when I ask you, Lars, whether this valve allow you to avoid discussions, to some extent, I mean, it's less stringent to have a surgeon around. A lot of us, I think, operate without standby. Who has a standby while doing TAVI? Who does it without standby?
You mean like no pump in the building
no
or something?
standby, meaning you do TAVI in case you have a problem, you call somebody. Hey, I have a problem.
But Francesco, listen here. I mean, having a surgeon in the hospital is 2 different things. You can have a surgeon somewhere in the hospital. He's not going to help you out if you have a disaster with an annulus rupture or LV perforation. There was a multi-center study published last year in European Heart Journal. Patient who's converted for emergency surgical during a TAVI procedure. 88% died within 1 year. So if you really want to have a surgeon who's going to change the future for these patients who have a disaster in the cath lab. The surgeon needs to be in the room. The heart-lung machine needs to be primed. There need to be guide wires in to put cannula in. Otherwise, it's not going to change anything. But a surgeon in the house can help you make a discussion on each single case, or at least the borderline cases, what is the best option.
That's why we have a surgeon in the room in every case. It is true, right, Greg?
Yep.
It's a requirement in the US that a surgeon and a cardiologist participate in every single case in TAVR.
Same in Germany. So you don't get reimbursement if you do not have a surgeon and a cardiologist in the room.
So by law, you need a surgeon,
Yes.
just like
But again,
when
a
you...
surgeon can't do anything if he's there by himself. He needs a heart-lung machine, a perfect...
The heart-lung machine is prepared.
Yeah.
It's
Well, that's going to change the future.
refinished twice a week, and it's in the room.
I think we're getting overly granular here on what the heart team is. Everything discussed. I think that all of us up here and many in the audience have spent a lot of time proctoring over the years and been in rooms. You can walk into a conference or into the room and know if they have a heart team or not. I mean, it's just obvious. So I think there's a lot of different ways to have a team as long as you have effect. And I think some of the things we talked about here are important. Surgeon and cardiologist in the room. Whether you have how many conferences, how you discuss things, all politics are local. There's ways to make it work. But I think that the team has to function. And a soccer team in Germany versus Italy versus France, they play differently, but they play as a team. And I think it's the same way with us. So the key is to have good results, reliable results, reproducible results. And there's probably a lot of different ways to spin it. I do agree that there are these subcategories of patients that are very well defined and very, very brief. If no discussion is probably appropriate. But I mean, the team needs to be the team.
Greg, thank you very much.
Thank you.
We're going to
Thank
ask
you.
the next...
Well, you're the only one that can cut me off.
No, we got to be on time. So we're going to ask Dr. Stefan to speak on the continuous innovation of resolving complexity.
Dear Saibal, dear Francesco, I'll now talk a little bit about two different innovations that may resolve some of the complexity, especially in mitral valve interventions. If you look into the mortality numbers, and I want to put this into the context of the heart teams, of course, you can see that indexed in Germany to the year 1990, the importance of heart valve disease is ever increasing and influencing the mortality numbers more than the more prevalent heart failure in Germany and the rhythm disease, including atrial fibrillation. The common concept for functional disease, which makes up about 70% of the treatment in Germany, is to treat the dilation of the mitral ring. The heart team decision may be influenced by a lot of different factors. This is Francesco from your publication in 2016. So, of course, we need a suitable anatomy for the mitral clip, but perhaps to move this a little bit away, you could also change the clip system in order to make the gray zone between surgery and mitral clip even larger than it is in the slide. This has resulted in a huge increase in Germany, and this is the German number of cardiac surgery repair in green, as you can see, over 20 years. And it's 7 years of percutaneous treatment in Germany. And as you can see, the total number of repair and replacement surgically has reached the same level than percutaneous repair in Germany. The anatomy of both the mitral and the tricuspid valve is complex. So there may be two actually innovations that can influence structural heart disease therapy here. And one of which is, of course, to have a multiplication of different devices in order to address different sizes and different gaps in the leaflet, but also innovations to visualize these two valves more precisely during your intervention. So the first innovation is a difference in steerability and size, and this is the upcoming MitraClip NTR and XTR, and you can see the size difference between the two. And if you open the arm angles of the clip here, you have a difference in about 5 to 6 millimeters between the two device iterations. There is a number of information, and I will not run short before Jean-François, who will address more the registries and the randomized trials, including the French information. But I just want to give you a short number
on the randomized controlled trials. As you may know, Co-opt US has finalized last July its randomization. MITRA-FR is finished since January 2017. ReShape 2, the successor of the ReShape HF trial, as of today has 330 patients out of 410. So 3 large randomized controlled trials will report the end of this year, by the end of this year or next year, their results. There are more than 65,000 MitraClip procedures, so you want to make this easier because there are 1,000 different centers doing these procedures. What is different? Well, one of the things I talked about is the longer clip arm, but you also want to have more stable steering with less rotation of the clip. A more predictable transeptal puncture is also something to aim for. So while the width has not dramatically changed, you can see that the possible cooptation length that you can force the leaflets into has changed from 9 millimeter as a maximum, with reality of about 8 millimeters, to 12 millimeters. This means that especially in degenerative disease, you can influence a larger area next to the clip by implanting your XTR clip in those patients. So there's about 3 millimeter more cooptation to the leaflet and the proximity of it than before. It's a more stable clip arm positioning, and there's a longer catheter, longer CDS catheter, that allows for 15 millimeters, 1.5 centimeters longer travel paths. So you're able now, in very largely dilated atria, to puncture 1.5 centimeter higher, which gives you a range of 3.8 to 6 centimeter in distance to the AV valve, which is extremely interesting in severely dilated patients. There's also the upcoming EXPAND trial, which will enroll 1,000 patients in 50 centers to look for these new valve iterations. And as you can see, the majority of centers using the new sizes in degenerative disease, as you can see in the first yellow column, with 74%. So I'll show you that new anatomic situations of AV valves are now treatable. This is a normal clip. It's a normal NT clip in the Triluminate study. And you can see you can treat, in this case, it's not the mitral, it's the tricuspid valve, before and after on the left and the right-hand side. But I have another case for you. Would you think that this valve is treatable? It is a gap of 16 millimeters by 22 millimeters. So who of you would use an edge-to-edge therapy in this patient? Perhaps almost nobody. But using an XTR clip, actually, it was possible to treat these patients. And you can see it's a consecutive amount of treatments, an LAA occlusion. It's a long clip, as you can see, and a short clip, an NTR and XTR in the mitral valve, and 2 XTR clips in the tricuspid valve. The result is shown here in 3 dimensions. You see a very stable bridge. And this is almost the combination of a clover technique, actually. And you can nicely see it in the side view. This massive TR has gone completely and is replaced by a trace TR with a gap of 2.2 by 1.6 centimeters before. What is also new, imaging is new. And what we'll see is more precise delineation of leaflet tips and leaflet tissue, as you can see with this new iteration. It's the same probes, it's just a different software algorithm that's being used. And the MitraClip looked like this the last 9 years. And it will look like this in the following year. So you have pseudo-realistic possibility to see artificial shadows, to control your device, to control the delivery catheter, but also the thickness and quality of leaflets, the thickness of tissue is now addressable for you. And you can see something that you have never seen before. It's a beating heart in your intervention. Cardiologists always lack the nice information to touch and feel the heart and to do sutures on the heart. So what we have to do is different things. We can only clip, we can look at virtual images, holographic images, but these can be very, very interesting. As you can see here, this is a MitraClip procedure in a heart that tells you where the central A2, P2 segment are. Those are the triangles, the blue triangles. So you can orientate your C-arm. You see exactly the edge to the LAA. The whole LAA is depicted here. You can move down, and the whole procedure, and this is in real time, took only 3.5 minutes. So
making the intervention faster and more reliable. And this is real time. You simply go in, it then closes, and this was the whole procedure for this patient. What we also see is that this is the iteration of a generation 3. What we'll also see is that we will not only get different lengths, we will also get different shapes of the mitral clip and perhaps a different steering system in the upcoming years. And the last innovation comes back to the heart team. And this is to initiate the first heart valve unit worldwide. So it's an integrated ward that only covers percutaneous valve therapy at our institution. It has a space for 25 patients that come there decompensated, that get their imaging, are being planned, go into the hyperdoor, go back to the heart valve unit station, which provides 8 intermediate care beds, and they're then discharged from the same heart valve team. So this was introduced this year at our institution. So my take-home messages are: structural heart valve interventions rely on innovations in imaging and device maturity. Those are new options in the heart team, and they offer a bigger gray zone for discussion. So we need these heart team discussions. The use of the mitral clip has been shown to be safe. Tricuspid treatment is underway. There is a new steerability, ease of use, and easier transeptal punctures. We can treat prolapse better, larger gaps. Imaging fusion and holographic display will enter structural heart therapy in the next 5 years. And of course, further studies and implant experience is warranted to validate these results. Thank you very much for your kind attention.
So we move directly to Jean-Francois Obadia, who will talk about the upcoming data that may bring new answers or new questions. You know, as Jean-Francois is leading the effort of France MR.
Well, thank you, Francesco, for giving me the opportunity to make this discussion. I have been asked to discuss about the French study, but also about COAPT and also about Tendyne within the next 10 minutes, which is really challenging. I will try to respect the time. Okay, there is no doubt that the mitral clip is a fantastic success story with more than 50,000 implantations worldwide and more than 1,000 publications on mitral clip therapy. But there is only one prospective randomized study published in 2011, and nothing. Of course, we have had many publications about registries and small cohorts or big cohorts, but no other prospective randomized study. And more important, if we compare to what happened with the TAVI procedures, you see that almost every year we have 1 or 2 prospective randomized studies published supporting the TAVI, while here, during those last years, there is a blank period without nothing. On one side, several thousand patients included in TAVI assessment, while in the mitral clip therapy, there is only 2,079 patients. And this is a real important question to answer. So if you look at this slide, you see the only prospective randomized study, EVEREST-2, with the first inclusion in 2005 and leading to the publication in 2011. And here is our experience in France, where we started slowly with the first implantation in 2010. And since we had absolutely no reimbursement for this technique, and we were a little group in France who were convinced of the potential capacity of the clip, and we wanted to be part of this innovation, we tried to submit a proposition to our Ministry of Health in order to get funding. It had been refused in 2011, and fortunately in 2012, we get some grant for our Ministry of Health, and we started the first inclusion of this French study in the end of December. And we have finished the enrollment 1 year ago, so that we will be able to publish the result for the first time in the next ESE in August. And our study has been published in 2015 in Eurointervention, and we have never changed the protocol from the beginning. From the beginning, the study has been designed and no change. It is a randomization 1 by 1. The people who were rejected by the collab, we joined a group, the group 3, and this group has also been followed by phone, but the main study involved the comparison group between the clip and the control group. One of the toughest decisions when you design a protocol is to assess the number of patients you have to involve in the study, and we based our estimation on this publication where you see that in these several thousand of patients, which were very severe, 20% of deaths during the next year and 41% of rehospitalization. And as a consequence, this is our primary endpoint at 12 months. It's a composite endpoint, death plus rehospitalization for unplanned heart failure, control group 50%, and we estimated that thanks to the mitral clip, it would be only 33% in this treated group. We have accepted 10% of patients lost to follow-up, and this led to 288 patients to be involved in this study. These are the French centers among all the territories, so that it was possible in France to get a clip in close to where you had the patient. And this is the enrollment, and you see that it has been very, very regular. This is the theory on the green line, and this is the effective enrollment. And at the end, we were in time, and we have enrolled a total of 307 patients. And of course, I cannot give you the result. I have not a clue because today the data are in the hand of the statistician, and I have absolutely no information so far. I will get the information within the next few weeks, and I will have to tweet them and in order to present it on the next August. But I can give you some information. For instance, the quality of the follow-up is very important, close to 100%. The mean age of the total population is 70 years. The ejection fraction for the global population is 33%, and the regurgitant orifice area 31 millimeters square. And more important, our hypothesis is verified since we expected 20% of mortality, and the observed mortality for the total cohort is 24%. So we are very close to what we expected. It is a very severe population. And if we compare to the COAP study have different story. At the beginning, 430 patients were supposed to be enrolled, and they had to change and to enlarge, and now it's 610 patients who were supposed to be enrolled in around 100 sites, and one by one randomization. And if you look at the rolling period of COAP, you see that the mortality rate is also 18%, and the rehospitalization 30%. So on both sides of the Atlantic, we have more or less the same target, the same population, very severe population, important rate of death, important morbidity, rehospitalization. So the two studies address the same group of patients. Now, if we compare the two studies, there are many important similarities. Two studies involve secondary MR. The patient have to be symptomatic despite optimal medical medication. They have to be hospitalized at least once during the 12 previous months. But it is also important to see the differences between the two studies. In France, according to the European guideline, the definition of the regurgitant orifice was above 20 millimeters square, while it was 40 in US, according to the US guidelines. Also, the primary endpoint is different. For our study, it is death plus rehospitalization, while it is only rehospitalization, and the result of COAPT will be provided by the end of this year. What is important also to understand when you look at this slide is that the number of centers is important, 37 in France, close to 100 in COAPT, meaning that the enrollment was 8 patients per center in France, 6 or 7 patients per center in US. That is to say, it is very difficult to enroll patients. It is very difficult to build those prospective randomized study, because if you look, it means 1 or 2 patients per year and per center. So it is, and when we know that besides that, more than 50,000 patients have received CLIP, we understand the huge discrepancy between the patients who have been eligible for this very important study and what was, besides that, the policy for the treatment of our patients on the daily basis. What is expected? There are different situations. Of course, if mitral FR and COAPT are positive, and that will be the jackpot for everybody, for Abbott, of course, for the physician, and more, first of all, for our patient, because it is a very severe population. Probably the CLIP will be the gold standard, and all new therapies will have to be compared to the CLIP. And also, last but not least, this recent and bizarre concept of hybrid MR will probably disappear. If mitral FR is negative and COAPT positive, which is likely because you have understood that the primary endpoint is less aggressive with COAPT compared to mitral FR, mitral clip, the conclusion will be that mitral clip improves the symptom but not the life expectancy, and maybe it will lead us to revisit the definition of functional MR, 20 millimeter square or 40 millimeter square. This has to be addressed. And now, if the two studies are negative, which is also possible, maybe the patient were too severe. We had to find signals among secondary endpoints and to define new prospective randomized study in more selected group of patients. The functional MR could be also only the consequence of the LVD dysfunction, and it has to be respected. This is another option. And maybe the residual MR plays a greater role than we previously thought. And this is addressed by this paper by the Alfieri team, where you see that when you have a residual MR after a clip, even if it is a small residual MR, at least grade 2, the prognosis is highly different compared to the grade 1. So when we have a patient who has a clip after a grade 4 regurgitation, and we finish the surgery with the implantation with a grade 2, sometimes we are happy, but clearly this is probably not enough. We also have to take account this only prospective randomized study in a surgical patient comparing mitral valve repair versus mitral valve replacement, where you see that repair is rather disappointing with 1/3 of the patient with recurrent MR after mitral valve repair. But also in this study, if we look at the subgroup analysis on the patient who had a repair and who had a successful repair, in this subgroup of patients, the mortality rate was lower, meaning that we have to pay attention also to the presence of the subvalvular apparatus, which is respected only when we repair valve. And this leads me to discuss about the tendine, because the tendine is really a new concept. As a surgeon, we implant those prostheses in mitral position, which is only an aortic valve put upside down in a mitral position, while when we use the tendine, it is a completely different paradigm with a tether, which mimics the subvalvular apparatus. And with this kind of device, we can get for sure, or almost sure, 100% of correction of the regurgitation. And this is the number of patients who had received a tendine so far, which is much more than any other device competing with the tendine. If you look at the result of the first 90 patients with a severe group of patients, the mortality rate was rather low, with the reduction of the MR, which is really efficient and durable. So that in conclusion, for the heart team, which is the purpose of our meeting, the good news is that we expect during next year the result of 2 prospective randomized studies, which were expected for the last 7 years. And if it is positive, it will be easy for the heart team. We will have to increase the indication for CLIP. But if it is negative, we will probably have to pay attention to the secondary endpoint and to have more selected indication for our patient. And maybe also to propose more indication for the tendine replacement, since the tendine provide more correction, a higher quality of correction of the mitral valve regurgitation. And we need probably also to have prospective randomized study also with the tendine. We don't have to wait 7 more years to get evidence-based medicine. So to answer to the question, we will have probably answers and more questions, and for sure it will not be the end of the secondary MR saga. Thank you for your attention.
Thank you, Jean-François. We are a bit beyond the schedule, so I will skip now the discussion unless there are burning questions. We go to the next topic, which is a combination of therapies. We go in the direction of replicating what is surgical standard to some extent. If the patient comes with more than one problem, get the solution potentially at the same site, and this will be given by Oliver Baker.
Yes, thank you very much for giving me the opportunity to present some data about this. So I hope that some of the data presented here can help you in upcoming discussions having on your heart team or with your colleagues. So I will discuss briefly, of course I have a limited time, I will touch upon combined valvular interventions, mostly aortic and mitral combination, also mitral and tricuspid, and then also some valvular intervention plus LA closure. So first about combined valvular interventions, what do the European guidelines say? Well, in fact, they state literally that there is a lack of data on multiple valve disease, and this does not allow for evidence-based recommendations. And if we look then specifically to transcatheter heart valve therapies used for combined valvular disease, then we see that we are actually only having case reports or case series. We don't have more evidence. So it's maybe important first to raise the question, is there really an indication for combined transcatheter valvular interventions? Well, actually, if we look to the important data from Euro Heart Survey and also the very large STS database with multiple 100,000 of patients, we see, first of all, that for surgery, if we look at what the surgeons are doing, that multiple valve surgery is not infrequent. So 10 to 15% of valvular heart surgery is actually surgery where they combine 2 or 3 different valvular interventions. Also, if we look into these databases and surveys, we see that these operations are typically associated with a relatively high operative mortality. 7 to 11% are reported, while ordinary single valve surgery is typically associated with 2 to 4% mortality. And also, not unimportantly, 1/3 of these patients have also impaired LV function. So just looking to all these factors, this just points to the fact that there is for sure an indication for transcatheter combined valvular interventions. And not unimportantly, then we even go over or we forget about the significant group of patients with multiple valvular disease who are deemed too high risk to undergo cardiac surgery. So I would say there is definitely an indication for this therapy. So first, the biggest group maybe, TAVI plus MitraClip. Very shortly, I have limited time, but if you look to a big meta-analysis from more than 8,000 patients, we see that, in fact, moderate or severe MR is pretty prevalent in patients undergoing TAVI. 15 to 30% of these patients have a moderate or severe MR. And this is also associated with worse survival prognosis. Importantly, however, it's important to state that you can see what happens to this mitral regurgitation after TAVI. You can see that actually 50% of these patients have an improvement of their mitral regurgitation, and the other 50%, you could say, stays stable. So I think these data advocate for a sequential approach that you should do typically first your TAVI procedure or your aortic procedure, and then you could consider your mitral intervention. Also, this is reflected in these data presented in a Spanish journal from a combination of 10 series, 33 patients, but this is the limited data we have. So we see that in the majority of cases, 9 in 10 of the cases, the TAVR is performed before the MitraClip, and this is also logical, and you see the mean time between those two procedures is typically half a year. Also important to state that the technical success of both TAVI and MitraClip is high, so more than 90%. This is very good, and actually limited number of complications. You see there's reported 1 major stroke related to a TAVI, a cardiac tamponade, and only one conversion to an open heart surgery. If you look to the limited follow-up data we have, then we see that these patients, well, according to the mitral regurgitation reduction is acceptable, but especially there is a good clinical improvement. You can see that there's still 1/4 of these patients. Of course, these are very comorbid patients, but 1/4 is still left with NIA class 3 or more. And then, in fact, only 15% 6-month mortality, 15% rehospitalization. So these are promising data. I admit these are very preliminary data. There's nothing randomized, but it shows that it is feasible, it's safe, and probably it has some good clinical outcome. So what do the ESC guidelines say? They state that in patients with severe MR, combined or sequential TAVI and percutaneous mitral edge-to-edge repair have been demonstrated to be feasible, but there is not enough experience to make official recommendations. So then the next most combined procedure for surgeons is mitral and tricuspid. Very short. So what happens what do the surgeons do? Well, we see that 35% of patients undergoing a left-sided heart surgery have also significant tricuspid valve dysfunction. So it's not infrequent. And then very logical, almost 90% of tricuspid surgery was performed concomitantly with another cardiac surgery. This is, of course, very logical. But very importantly, if we look to MitraClip patients, then we see that many of these candidates or patients who undergo MitraClip also have a significant tricuspid regurgitation. And this tricuspid regurgitation has also been proven to be a predictor of 1-year mortality in several papers. This is a paper from European Heart Journal in 2015. But this is also a very nice article from Eurointervention last year, where it shows that on the left-hand side that both tricuspid regurgitation severity at baseline, so this is before the MitraClip, is predictive for a worse outcome from your MitraClip procedure, or from your patients undergoing MitraClip, but also a no TR improvement. So if the TR doesn't improve after MitraClip, these patients also do worse. So this all points to the fact that probably some group of patients could benefit from both a mitral and a combined mitral and tricuspid intervention. These are the limited data I found. So 22 patients reported by Nickenich, 12 patients by Brown. Be careful, this is off-label use of the MitraClip system, which was also used to treat the tricuspid. You can see success rate very high, duration of the procedure acceptable, no procedural death, so it's a safe procedure. The TR reduction is, I have to say, acceptable, but not spectacular here. But as I said, this is not a dedicated device for TR reduction. And of course, Abbott has been working the last few years on a real clip-based technology, a real tricuspid, specifically for the tricuspid valve. And they have already started the TriLuminate. This was mentioned before, the TriLuminate CE Mark trial. I think this is the aim for 85 patients. I think there are 30 or 35 patients have been enrolled so far. The target population is patients with symptomatic patients with a moderate or greater tricuspid regurgitation, and the endpoint, efficacy endpoint, is an echocardiographic endpoint with a TR reduction of grade 1 or more at 30 days. So these data will soon be expected. Then very shortly also something about the combination of valvular intervention, so specifically TAVI or MitraClip in combination with an LAA closure. Is there an indication, or is this just a physician need to do this? Well, I don't think so. I think there is actually a real clinical need. If you look, there is a very high prevalence of, first of all, atrial fibrillation in both MitraClip patients. Of course, they have mitral regurg, big atria, so very often they have atrial fibrillation. But also in TAVI patients, it's extremely prevalent. It's up to 35–40% in some series have atrial fibrillation. And then interestingly, if you see from 1-year mortality data from the Partner 1 trial, you see that actually patients in sinus rhythm, they had a 1-year mortality of 13%. Having atrial fibrillation gave them a double mortality, and having experienced a major bleeding gave them an exposure of a 4 times higher mortality risk. So this is a significant clinical problem. You talk about major bleedings in patients with AF undergoing TAVI. How should we see this? Well, I think if you see it in combination with TAVI, you could do it either hybrid or sequential. In MitraClip, I think it speaks for itself that you could do it as a hybrid procedure. You are already in the left atrium, so you could close the LA on the way out. I I show you briefly data which we soon will publish from Copenhagen. So this is from 2 years ago data where in 1 year we treated roughly 310 patients with TAVI. As you can see, 38% of these patients have atrial fibrillation. This is a typical number. And then what we did is we selected 20 patients. This was not randomized, but we selected 20 patients at high risk for bleeding, and we treated them with LAA closure. Just to show you, this are the 180 patients, TAVR patients plus AF. You see all of them have a rather high bleeding risk if you calculate their Hasblad risk score. These are data from the 20 patients we selected so very often they had had a previous bleeding or they had had PCI 3 months before their TAVI or chronic renal failure. 90%, so 18 of those 20 patients had a Hasblad of 3 or more. And these are data, pretty good data, I could say. All the procedures were done in local anesthesia, also the LA closure with ICE guidance. So procedural success was 100%. So the 20 TAVIs and the 20 LA closures went completely uneventful, no complications, and 100% procedural success. And we have from all these patients now 1 year clinical follow-up. And I want to point you out, this is 20 patients which were having a high bleeding risk. You can see they had 0 major bleedings at 1 year follow-up, while in the TAVR population with the typical combination where we gave NOAC plus a clopidogrel then for the first 3 months and then a NOAC further on, there was 10% of major bleeding in this group. So this was significant reduction. And also, this was not significant, but mortality was half, 5% in the patients having an LA closure compared to the ones on NOAC, it was 11%. Very short, I'm almost at the end. So MitraClip plus LA, this is only few cases we've done in Copenhagen. Just a very short example, a patient with severe MR, permanent AF, also recurrent gastrointestinal bleeding with transfusion need. I don't show you the pictures, but just look at the time. This was a live case. So this was still before the MitraClip went into the LV. This was at 10, 11 a.m. 50 minutes later, the MitraClip was placed and the LA closure was done. So I think it's an easy procedure. MitraClip, of course, first, followed by the LA closure. Height of the transeptal puncture has been discussed. I don't think this is an issue. It's particularly appealing for AF patients with absolute or relative contraindication. Of course, long-term results are missing. So as a last slide, I think it's important to know these data that very often combines valvular heart intervention. Data which are available right now, they show that it's safe, it's feasible, and it could be considered. Also, if you have such a patient at your heart team meeting, this should not be a reason to refer this patient automatically to surgery. I think it should be discussed thoroughly. Whether LAA closure should also become a topic of discussion at the heart team meeting, I don't know. This is an open question, and whether there's a role for a neurologist in the heart team meeting, personally, I don't think so, but it is an open question which could be discussed. Thank you very much.
Thank you very much. We're really running short of time. I think we have a couple of minutes for questions for the last 3 speakers. It's open to discussion among panel. Greg, do you want to make any comments?
Yeah, I think the thing that was most provocative to me on the combined therapy is something that we've certainly done more and more in surgery, which is combine mitral and tricuspid, and emerging data showing that it really improved the survival. And I think now that we have great data on MitraClip, and we certainly know in TAVR, that TR is an indicator, independent indicator of survival or mortality at 1 year. That I think we really need to start focusing on designing trials to address TR, not as an independent disease. We have great data on the surgeons for the size of the tricuspid valve and the degree of TR when we're doing a mitral valve intervention. So I hate that we would wait very long to introduce that into our transcatheter options. And any thoughts on that from the panel?
I have one question to you, Jean, about the 2 mitral France and the COAP study. Mm-hmm. I have a question about the endpoint difference. The endpoint in COAP is just rehospitalizations from heart failure, and not having mortality as a co-primary. Does that concern you?
No, I think it's less ambitious, and maybe it makes sense.
We are less ambitious?
No, the COAPT, because they only address symptoms, they don't address the mortality.
Right.
And when we designed the French study, it was a little bit earlier, and we were really confident in the first result we had on our patient, and we expected to have a positive answer in this population, but It is true that the population is severe, and we are not sure that the result will be positive. And it is more likely that COAPT will be positive compared to METRA-FR, since there is a difference between the two endpoints. You are right.
So, but I have one concern about not having mortality, because, a dead patient can't be readmitted.
Yeah.
So if you have more dead patients in one arm, they will not be readmitted for heart failure. So we may lose in the study because of that.
Yes, this is yes, but we as soon as the patient is dead or re-hospitalized, he has reached the endpoint. So in both
No,
groups,
actually, it's a cumulative endpoint. So if you reach one heart failure admission, that's not the endpoint. It is the number of admissions.
No.
So if you have a patient who's had 4 admissions of heart failure, and the other patient has only 1,
Yes.
Then the person who's had 4, it looks worse.
No, we only had consider the first re-hospitalization. In a secondary endpoint, we have the number of re-hospitalization. But in the first,
so that's the fundamental difference between
yeah, absolutely.
Okay.
Yeah, absolutely.
All right, with that, I'm going to ask Dr. Maisano to speak on the final talk and also give his final thoughts about the topic, heart team, democracy or autocracy.
And I didn't choose the topic. Somebody gave it to me. But I'm pretty happy to give this talk and to make it, usually if I see a topic like this, I leave the room. I think it's boring. So I'll try to make it not boring for you guys. So I presented this slide at PCR 2007. I was invited by Jean Macot. I was a young surgeon. He invited me to give a lecture on the heart team. And at that time, it was clear to me that there was a merging of professionals. And TAVI was, at that time, the joining force, the reason to join forces and to go somehow either together or in conflict. I mean, there was both possibilities there. So, 2005, for the first time, the STS, AATS, and CIA wrote a position statement on this topic, telling that percutaneous heart valve treatments require skill set independent of the operator's base discipline, and that specific training should be required. So basically, at the beginning, there was a lack of skills, which was pushing people to work together. So I participated to this position statement in Europe with Alec Vanyan as a first author, stating for the first time that the heart team for structural heart interventions is desirable. Later on, 2012, the heart team has been named important in US, and the ESG guidelines that stated it is mandatory. So basically, we went from a necessity to a regulation. This is how I see heart team in my practice. I divide my practice in 3 eras. The first era is pre-CE mark, early stage, talking about PVT, first cases with Antonio Colombo. It was at that time before CE mark, feasibility of TAVI in extreme risk patients. Then CE mark came, and there was a rapid adoption of these procedures, mainly in all patients with comorbidities. And finally, we are now in the more mature stage, where TAVI is first choice in intermediate risk patients in my practice. I'm not a surgeon who is saying no. I'm sometimes say yes a bit too often. So, what was the heart team at the beginning? It was fantastic. We were just a team. We were navigating into difficult water. There was need for complementary competence. We were covering our skill gaps. We were managing frequent complications. The conventions were very rare because we decided not to operate these patients. This was a small, integrated, functioning team with partners. We were really partners. And there was a heart team, and there was people outside of the heart team, which were really envious and against us. Mm-hmm. Then the heart team became larger. The early guys who said at the beginning, we are not participating to these crazy procedures, people will die, 20% mortality. Then people come. The heart team becomes larger, more fragmented, becomes a political infrastructure, the guidelines come. Still, there is some complication. There is room for some cross-training and a lot of several complication management, so access issues, some conversions, etc. Today, this is not anymore the case. We ask ourselves, I ask myself, do we need to be in team? Do I need a cardiologist myself? Or a cardiologist will say, do I need a surgeon in the room? I don't need it. I mean, why do we have to be two at the table at the same time? So today is the question whether we need a different definition of the heart team. Do we need the heart team overall? This is the question. Well, this is a slide from Martin Leon, who was elaborating about the heart team, prediction that mitral valve will keep us together. The heart team 3.0, it goes even beyond, will be a very complex infrastructure having the patient in the middle. The problem is that we have a very wrong misconception of the heart team. It's totally wrong. I mean, I'm sure that you don't know what is the heart team. Very often we refer to the heart team to this picture. Everybody rowing in the same direction, united, we win. Well, first of all, these are 4 people doing the same thing. It is really not efficient. Why do we need 4 people doing the same thing? And we don't navigate in shallow and easy water. We are under very difficult conditions very often. It's very difficult to work together. And in this kind of conditions, you need to have multidisciplinary skills. Everybody should trust each other. Everybody has a role, which is recognized, respected. And if anybody of these guys make the wrong decision, it's a failure of the whole team. This is the heart team. This is the team, a team approach. But in reality, this is what it is for us. We have to go to this meeting once a week, and I hate it, to go in this room. If I go as a surgeon, sometimes I put the jersey of the surgeon, sometimes I put the jersey of the interventionist. As a surgeon, to be there, to be the judge, say yes, no, okay, like ancient Romans, kill him, not kill him. So the reality, we have been trained to be individual, independent. Our training is based on that. We compete to be the number one. In this room, everybody here is a successful guy. You have been able to be sponsored to come to PCR. In your clinic, there is at least 80% of the clinic which is staying there is working for you. You are successful. You are the leaders. Now, this is a competition where we have been trained, and now somebody tells us, now we have to cooperate. So the reality, this is the real heart team. We are gladiators fighting for patients, or let's say, fighting for building, or whatever, fighting for career. So, and now come to the democracy, autocracy. It took me a while to understand what the heck I should talk about it is. But the problem in the heart team today is who is leading the heart team and what kind of leadership is needed. So in leadership, this is a typical leadership model. In a team, you can lead the team with democracy or with autocracy, which means, a simple way, I can be the leader, I decide, the other should follow what I decide, or we should discuss every single case. So Ganesh proposes that we should have one guy deciding, the other following, or, in the majority of patients, let's say under some conditions. There are other people who may decide that democracy is better. Now, an autocratic style of leadership is very efficient. Decisions are taken very fast. I decide, we go. Look at, there is cybercar was getting asleep about this. But look at this. I'm a surgeon, and you don't want to be a surgeon, right? You don't want to be a failing category in our profession. So autocratic leadership was very common in the past in surgery. This is a picture of Professor Sauerbruch, who has been the first director of the surgical department in Zurich, where I work, between 1910 and 1918. He was making rounds with a general uniform. He was a general. And this was the way to run the business. I am in command. Very direct. Now, I will make the point that this is not working long term. Short term works. Look at what happens in the world politics. after the Second World War, I was impressed. I saw the highest number of nations with a non-democratic system was much earlier. Actually, in the 70s, there has been the highest prevalence of non-democratic governments in the world. And you know why? Because autocracy, or let's say despotship or dictatorship, is a good solution in systems which are anarchic, unregulated. In lack of regulations, in lack of rule of engagement, you know, somebody takes the lead. But overall, democracy wins. And why does it win? Democracy is the only way to survive the changes. You need diversity in your team. If you don't have diversity, you don't survive the change. And there is no system who has not been killed by not being diverse. If you are not diverse, you're going to be killed by the change. And the change is happening. I mean, what we're treating today is a different patient population that we were treating 10 years ago. This is a lecture given by Mike Dale. You know, I have to acknowledge a great lecture showing that today we are in the era of chronic care, not anymore in the acute care. You know, acute myocardial infarction has been solved by Grunzig and followers. And you already are out of that business. This is already standard practice. TAVI, sorry guys, is almost commodity. It's not anymore fancy to be a TAVI operator. You need to be a mitral operator, tricuspid operator. Globalization is happening. What happens in Europe, probably in few years, Europe will be out of the innovation cycle unless we change style. We have a lot of problems in our financial model, and the financial demands on physicians will change the way we're going to deliver our healthcare services. We're going to have a number of different competitors, including artificial intelligence. If you have seen Google CEO keynote speech, 1 week ago, he made a very important keynote speech where he declared that healthcare is going to be the #1 target of Google in the future. We have problems with regulated duty hours. These kind of pictures will not be anymore able to be done, and there is an increasing regulatory demand. And very importantly, you know, what we learn today is already obsolete in 1 or 2 years. So under these conditions, I think we need to be open to diversity. We have to find a way to be open. Convergence is the way to move forward. There is a lot of areas where convergence is fundamental, and I think one of the areas is cardiac surgeons and cardiologists, interventional cardiologists, are very similar. We need a new team which is enabling cross-fertilization, interaction, exchange of culture, to go beyond collaboration, being partners, focusing on synergies and similarities, trying to be really together, because complementarity is only temporary. If you really work together, you become more similar. We need to emphasize on competence rather than skills. I mean, I'm a surgeon defined by knife. No, sorry, guys. I don't accept this, that I am a surgeon because I can use a knife. I mean, I am a surgeon because I like to intervene, like you want to do. And if we look at the change in the regulations, this will be very important. Because value-based healthcare will move ourselves from intervening and implanting to be able to run the full business. So we need to really try to go into this convergence modality, and I'll show you my experience. This is Maisano, I don't remember, 15 years ago probably, with Antonio Colombo at my very beginning. I was very proud of being there and collaborating with a lot of other physicians. And after 15 years of working with interventional cardiologists, I don't accept anymore cardiac surgery be part of surgery. I want to see this, and now I am a director of cardiac surgery in a university, so I will work on this. I think interventional cardiovascular medicine is the common platform that we have to foster together, because you are more similar to me than your heart failure specialist, which is working next door. He is going to be your next enemy. And we need to fight against this enemy in the future. So together we need to find a new training pathways. I believe in a common background in cardiology to build a new class of leaders. And I want to share with you my own experience on an experiment. I can see one of the scholars of this, which is actually is not anymore a scholar, actually is an alumni of this certification. We have been working last year in an interesting project where we have been certifying leadership in the heart team. It's a mixed class of intervention cardiologists and surgeons who came to this school, and after almost 1 year of work, I think they became aware of the necessity of having common grounds. The skill set that we've been trying to develop in this program has been a mixed skill set of clinical competence, leadership, science, and innovation. Because education is the next frontier, and the next frontier we are opening now the mitral structural interventions. We will start in October. Because I really believe that our profession is not ending. Although we are all at risk, there is always a cycle. So our history is plenty of legendary leaders, and you see Barnard, by the way, he was also legendary. Guy was dancing with Grace Kelly, was on all newspaper, Time magazine. And you can see Grunzig. So who will be the next legend? And again, this is a big misconception that we have, guys. You know, this was what we thought about being a legend in the past. The future is this one. Because I think the future is not a single person, it's a community of leaders with specific skills working together, which are going to be unbeatable because they will be unique by encouraging diversity. Thank you for your attention.
That was the last comments, right? So I want to ask a question, provocative, since Ganesh brought it up. And this is to Greg also, that we do a lot of cases, patients come directly to cardiac surgery, right? And would you then discuss with your cardiologist all cases, whether this should be done an interventional approach or?
Well, I think I go back to what I mentioned earlier. When you visit a center where that is done, you can feel it the moment you walk in the room. And when it's not about competition, it's about collaboration. And it really just, that paradigm does so much. We take better care of our patients. If we're study sites, we enroll better in trials. And I think aligning vectors and to a mutual goal, that becomes very easy. And yet, to answer your question, sorry for the digression because you cut me off earlier. But yes, I do. If I get referred to a mitral valve patient or an aortic valve patient, we do our best to present everybody we can. If there's
that's it. Yeah. Yeah, I do agree that people cannot be always triple-threaded, but departments can. Right.
Exactly.
And everyone can't have the same set of skills, but two people can have complementary skills and actually make it a big difference. And I think probably there's going to be a blur of actually departments being like cardiac surgical department and cardiology, and it's just going to be cardiac sciences. Do you agree with that, Jim? I mean,
yes, of course. I think we should agree with about which patient should be discussed and which patient should not be discussed.
Right.
But for doing that, we need more prospective randomized trial in order to get more precise guidelines. Because, for instance, with the TAVI, so far we have a lot of evidence-based medicine. So I think that we can skip 80% of the patient, and for instance, say any patient above 80 or 85 or 75, depending on the situation of the hospital where you work, shouldn't be discussed. And we admit, surgeons and cardiologists, that all those patients should go for TAVI. We can admit that below 50, for instance, all the patients go to surgery. And we just discuss a group of patients. But to do that, we need evidence-based medicine. This is why I strongly encourage to enroll more patients. And again, this is absolutely mandatory in the mitral field to have as much evidence-based medicine as what we have for TAVI.
I want to just we still discussion between surgeons and cardiologists. Who cares who is discussing?
Yeah, I agree.
Please discuss with somebody. I don't want you to discuss with the surgeon. The solo decisions are very dangerous. I tell you, this is the main issue. I don't care who's going to be at the heart team discussion. At least I need 2 people. Please, challenge me. Challenge my opinion, because I make mistakes myself. So discussion should not get out of the equation. Whatever is participating to the heart team discussion. But discussion is fundamental.
Yeah, but what I was saying is not surgeon versus cardiologist, is indications. Yeah. And we agree about some indication. Let's say, for instance, every patient above 80 should go directly for TAVI without any discussion. And this is something we can admit in one institution.
Are you sure about that?
No.
You have a patient who has a LVOT calcification and maybe has no growing access and needs to do a transepical, whatever.
Yeah, of course.
Is it 80?
There are always exceptions.
It's very difficult to say this patient should not be discussed.
Yes,
and again, discussion is exposing yourself as an operator. I hate discussion, to be honest. I need to do it. In the operating room, we are obliged today to do a checklist, which is discussion with the anesthesia, to make sure that you don't operate the left side instead of the right side, for instance. Everybody hates that, but it's a security feature to make less mistakes. We do mistakes. I do mistakes every day, and I do much more mistakes when I'm not challenged.
What about, everyone talks about the cardiologist, the surgeon, and maybe the heart failure specialist too now. What about the patient? Don't you think the patient should be a part of this whole discussion and his preferences should be taken into consideration?
Who disagrees on that? We all agree with that, no?
We all agree on that, but the insurance companies don't agree on that. I think that's a major difference. So in Germany, a patient plays a role in the decision making, but not officially in the decision making that's done on paper versus the insurance company, because they don't respect the wish of the patient.
But it's even in European guidelines.
Exactly. So
I know.
Now.
I know. But there are certain legislative.
But that's also going to change by time.
It will change.
I mean, none of us is going to accept to be dictated what treatment we're going to have a view ourselves.
But we also have to think about the qualification of the heart team. I think that the training efforts, actually, Francesco, I like very much. But how is the reality in Europe? How is the reality in the US? For a heart surgeon who wants to enter an interventional or percutaneous group, how is his training organized? Does he get wire skills?
It will never happen until we don't understand that we should all start from common cardiological background. The next generation surgeons in my institutions will be cardiology first.
Okay,
anyhow,
quick comment.
Let's do. No, it's not a comment. I think it's question. Late. No, wait a second. We need your words of wisdom, so you will conclude the session. Okay?
Oh, that's different.
Gus, you conclude the session.
Good conclusion. Patient's opinion. We cannot be mistaken. It's overplayed now. The poor little old lady, she doesn't know what the heart is or anything. They need your expert opinion. They want what you think is best for her. You cannot ask her, you prefer the chest open or a balloon or a stent. They want your opinion. So they need to be well informed. But the little old lady is not a cardiologist or a heart surgeon. They cannot give an opinion. So that has to be clarified.
I think that's not the reality. The reality is that every patient is informed on the internet.
But they cannot decide what's best for them. They don't know.
There's a whole family behind it, and they have a very structured opinion. I think what you point out is not the reality.
I think it is, absolutely.
I don't think it's
like me for a brain tumor.
In my
if I have a brain tumor and I go to a neurosurgeon, say, what do you prefer? I don't know. That's why I go to an expert.
To stop the discussion, I thank everybody for the discussion, and I propose next year we do a heart team discussion based on the patient. So we will discuss these other complementary issues. Okay?
And thank you very much to all the speakers and panel members.